So now we invite Dr. Rohit Omprakash, sir. He is senior ophthalmologist and head at Dr. Omprakash Eye Institute, Amritsar, Punjab. He has been actively involved in the phaco emulsification education training program for more than 20 years. Over to you, sir.
Yeah, so I will be creating a temporal incision, which would be 2.8 in this patient. Now I dip in, and you can see the incision is done. The next step is I introduce a visco. You just give me the visco. Yeah. I'm using methyl cellulose here. Side port, I'm sorry I don't have the 25 gauge needle with me to show the side port calibration. Usually what I do is, I need fine focusing. I use a 25 gauge needle for that matter. So I would be going in partially. Capsular axis forceps. Give me some visco. I do capsular axis with the capsular axis forceps. There it is coming. Hold it again. Hold it from this side. The chamber has collapsed slightly, don't bother. Go close, keep close to that. And the capsular axis is completed. Was it clear, sir?
Yes, very clear. You're very confident you're not using any instrument to stabilize the globe.
Yeah. Hydrodissection with the 2cc1. I'm not used to it. I'm sorry for that. So I usually use a side port instrument, which is a 500, which is a 25 gauge needle. This 25 gauge needle has a calibration of, has a size of, 500 microns. And my instruments are such that the phaco chopper which goes in has 450 micron size at the proximal end of the shaft and 400 at the distal end. So what happens is, so it helps me in manipulation. Now I'm going to do the wave will come now. I'll do it again.
You got a small wave, no problems.
Yeah.
Yeah, now it's done. Yeah.
Yeah.
Now, of course, your
I need the
hydrodelineation.
2.8 one. Is it the 2.8 one? The sleeve? Yeah. 2.8. इसमें है. I think it is there. Can you give me some visco?
Rohit is from Amritsar and a very gifted surgeon. I've seen a lot of live surgery from him. And also, more importantly, he runs the Winter IRSI every year. He's a wonderful host. If you've not attended that conference, I would encourage all of you to make some time and visit Amritsar in January, I think. Is it right?
Yeah, that is why we call it the winter one. Because the rooms are cold, the atmosphere is cold, other than the venue.
But the hospitality is warm.
Yeah. So
any particular reason you're using a 2.8, or do you usually?
At times I use 2.2, but here I thought I'll use 2.8. So I'll be doing the stop and chop because you have seen the direct chops. So today here I'll be showing the stop and chop.
Sir, your phaco settings are a bit different from what it is used. Vacuum, you are used to lower vacuum, I think.
Yeah. How much is the vacuum?
180 maximum.
Yeah, I think it should be okay.
Slight
I think this just goes to highlight that there are no.
Light की तरफ देखिए. Look towards the light.
Each surgeon needs to find
Look
his
towards the light.
comfort in terms of speed at which things are moving in the AC, the suction force that is going to be there, how much of occlusion you're using at that point in time. I think each surgeon needs to find. There was this question often asked earlier: what are your settings?
Yeah.
I think that has become redundant over the years.
You know, everybody is used to different things. Can I get the quadrant?
If you can center it a bit, sir.
Yeah.
Yes, it's fine.
Is it focused now?
Yes, yes, yes.
Now it is focused. Quadrant? The chop, because the pressure is very low. Light की तरफ देखिए. Light, look towards the light. Yeah, now it's okay. The rotation is being done. Go full thickness, hold it and chop it. Now again, go full thickness, chop it. Now again. Can you see the chop?
Yes, we could see the chops, but
What?
you're only on coaxial illumination,
Light की तरफ
so
देखिए.
slightly dark.
Is it dark? No?
It is dark, so you could probably increase.
Comfortable adding the oblique, Rohit, that would help us. But if you're more comfortable with just the coaxial, it's okay.
I'm using the retro illumination.
Yeah, that's what. So, could you add on the oblique? Then the picture gets a little clearer for us. And if somebody is there to manage the hall lights,
देखो light.
Aditi, who's the hall? Aditi, Dr. Aditi.
I think here the illumination. Light की तरफ देखो. Ask in your language.
You'll have to say "Alo dekhe taka."
Yeah. Light. Yeah. IA. So I use a coaxial IA with a curved tip because I was in that phase where people started using the coaxial one. But I have some very little indications for using the bimanual, that is when there is an open posterior capsule wherein you want to separate the irrigation and aspiration levels. And if at times the capsular axis is small and you cannot take out the subincisional one, that is one indication when I am using it. Yeah, this is 2.2. This is, give me the 2.8 one. No issue. There will be leakage from the mains. So I'll bring out the 2.8. 2.8 wala dijiye. And, and in patients who are using tamsulosin, there also at times I use a bimanual one. I usually, yeah, there it is. There was some bit of epinucleus also.
Here are the lights, sorry. Yeah, I want to cut off these 3 lights. Okay. These 3 chandeliers can go off, the last 2 can go. And these lights, all lights till the front half. Cut off all the lights.
Now comes the subincisional one. After this central epinucleus comes out. So go at a low vacuum, hold it, and bring it out. This is the last. I think it's absolutely clear. Yeah.
Yeah, we're getting a very good glow and we can see the excess margin. So what lens are you planning to use, Rohit?
Sorry?
What lens are you planning to use?
I'm trying to use 80 Lisa from Zeiss, which is a trifocal one. This is my preferred intraocular lens. Basically, the advantage it gives, it's a plate haptic one, and when IOL is being loaded, and when we use a plate haptic one, the first thing which comes in one's mind is that at times the rate of PCO would be on the higher side, but in this, they have some coating which has an anti-PCO posterior capsular pacification coating. In my 2.5 years since the time when I've been using this intraocular lens, I have not had a case wherein I had to do a YAG laser capsulotomy. So in my practice, another advantage is that it has a system. I'm waiting for the lens. In my system, that is the first thing. The second thing, which it has a built-in SMT feature, which gives the least amount of glare. So that is another thing which is there in this, and the implantation is very good. Are you ready with it? So this intraocular lens, as far as using the torics is concerned, the side with the straight one, even if you don't forget it, if it is taking time, go in. Let's see how it goes in. It really goes in nicely. Last point, you just nudge it in. Side. Spatula side. Yeah.
So I believe, Rohit sir, is that in this plate haptic or the tetrapod haptic lenses that we have, the overall diameter, since it's on the lower side, it is absolutely imperative for you to construct or fashion a CCC which is even smaller than the optic size, and you must have a proper overlap.
Absolutely.
It's a little forgiving when it comes to the modified C-loop design, because that they have more equatorial stretch, and so the bag does not collapse. But in here, you should have a proper shrink wrap and the ring of sommering developing later on, just to hold it in place. But I completely agree with you. The Zeiss IOLs actually have a very good talkative term with their biometry machine, the 700, the IOLmaster 700. And the post-operative refractive results are excellent. You don't get surprises that easily. And after they have come up with the hydrophobic surface modification concept, the PCO rates also have significantly gone down. So you have almost the best of both worlds. You have the hydrophilic material at the core, which makes it extremely malleable and soft to get in through a 2.2 easily. And then you also have the hydrophobicity on the surface, which has all the typical properties to prevent the occurrence of PCO to a greater extent. So I agree with you.
Just one question is, let's say for high myopic eyes, do you have larger dia lenses? I mean, the larger overall dia lenses?
I don't think so. They
I
don't.
know. No.
So that would be an issue with these plate haptics. So
Some
that is-
people recommend implanting a CTR before implanting the IOL. I don't know. They say that it works very well in their hands, at least. I don't have any personal experience, but that's one of the things you can think of, Dr. Shubhen, because the back size is too large, so
Yeah.
you can just stretch it at the equator so that it doesn't collapse.
Chilling.
But if it does, then there will be a problem. And I think apart from the multi-piece designs, multi-piece modified J or modified C loop designs, I think this particular thing
Okay.
holds good for all IOLs across. I mean,
Yeah.
even if it's a modified C loop, if you have a very large bag, then it can always compress it and displace it. It can tilt it, it can cause an anterior displacement, causing a myopic drift, or it can cause a tilt of the IOL, causing an astigmatic drift. So these things are possible even with a modified C loop design. The only thing that safeguards you against all these effects is
Oh,
आवाज
Yeah.
क्यों आ रहा है?
last.
but unfortunately, we don't have the AT platform, the advanced technology IOL platform available
उधर से
to us
बंद
in the
करना पड़ेगा
multi-piece design. So then if you're
नहीं,
choosing
वो mic
the
का आवाज
the
कर-
multi-piece design
अभी on है मेरा।
from this point of view, then you have to compromise on the multifocality
ठीक है।
or trifocality or even toric.
हाँ, लगाओ।
I mean, being a platform of choice for you for that particular patient. So
I'm very much,
सीधा देख।
concerned about the integrity of the wound,
इसको ना एक
And nowadays I've
drop
started
डालो।
using
ये
intraoperative
अभी एक
OCT
मिनट रुक जा वैसे।
to see the integrity of the wound.
बेटे आंख बंद रखो।
Because at times there are leakages which we
Keep
are
your
not
eye
aware
closed.
of. So that has helped us a lot and we are doing a study on it. So I think it's perfectly done otherwise. Yeah.
Yeah, wonderfully done. Perfect. Could we have a round of applause for Dr. Rohit Omprakash?
बस ठीक।
Thank you, Dr. Rohit.
चलो
Yeah.
लगा दो।
I think it demonstrated
Hello.
very well that the hydro procedure should be done after you loosen the speculum a bit.
Keep your eye closed.
Yeah.
Always be done.
Absolutely. That is why I loosened it and then I did it. But then, it is obligatory and at times where I feel that there is some bit of leakage and if I do not have an intraoperative
29 थोड़ी आएगा।
OCT in hand, what I do is I use Tripen Blue
हैं?
to see whether there is any leakage or not.
आएगा
What
कितना?
we have done lately is that we are doing Tripen Blue, this Seedles on the next day in all the patients. And we find that the side port leakage is there
वापस
in
से।
at least 3 to 4 to
Back.
5% of
ठीक है, छोड़।
patients even after 24 hours. So that point and
Eye बंद
no
रखो।
doubt the pressure is okay, the lens is, the
थोड़ा
anterior
नीचे
chamber
करिए।
depth is
बस।
perfectly fine, there is no cellular reaction. But then we watch again but the seal on their own within the 36-hour period.
So what we have to remember is the patient has been, the patient in question has kept his eyes open for a long time
Yeah.
when you were doing the surgery. So the moment you release the pressure on the lids, it is a natural tendency
To squeeze. Yeah.
So
You just loosen it.
so
So that the patient gets the required adjustment and then
Absolutely.
gradually.
So you don't, the message is you don't withdraw your eyes from the eyepiece. You don't take away the microscope immediately. After you
बंद
release
रखो।
the speculum, just watch it for a few seconds. If it's doing fine, then you can carry
eye
on with
dry
the
हो
next phase.
जाएगी बंद।
Yeah, and there's another side
Another
to it.
important
that
thing
when
which I
you-
do is that even if after I release the the speculum, I recheck it because occasionally, once in a while, there is some amount of the chamber collapsing is there. Because if we are doing a temporal incision, which I did, it is obligatory and mandatory that the main port has to be totally sealed. So I spend, quite contrary to what majority of the people do, I spend at least a few minutes more on it rather than,
Minutes.
the whole procedure.
Hello.
Dr.
And,
Shubhen, yeah. Yes, Dr. Shubhen.
Yeah, and there's if you finish the surgery before you loosen the speculum, you get a false sense of the chamber being tight.
Yeah.
Actually, if you would release the speculum a little and then call it a day, it makes more sense.
Yes.
So it is a matter of individual preference though, but I mean, I just tell you what I do. I normally do not use these self-retaining speculums for my Phacos. I always use the wire speculum. So they're easy to dislodge, and within seconds they come out, and they don't put as much pressure on the lids. And if you release them in a jiffy, then even if the patient closes the eye or squeezes the eye, there's not much of a pressure, so it doesn't press against a counter pressure that is already existing through the speculum. So it's an individual preference, of course. I mean, with the wire speculum, you don't get as much exposure as you get with the self-retaining ones.
Yeah. We were having problem. We used to use those speculums initially, but then shifted to them. But then, you know, as you said, each one has his or her own way of doing things.
Absolutely.
Yeah.